Thank you all for being here. I'll just make a quick introduction and then I'll let Dr. Wang go ahead and give his presentation. My name is Harlan Adler. I'm the co-founder and chief executive officer of CERVOS Medical. For those of you who aren't too familiar with CERVOS, we're really a pure play autologous biologics company and a subsidiary of the company. I'm also the CEO of Ranfac. Ranfac's an established medical device manufacturing company. The product that you'll hear about today is 100% manufactured by Ranfac, as is really the entire CERVOS portfolio, including our PRP system, our fat grafting system, and range of intraosseous cannulas. We're based in Boston, just south of Boston, Massachusetts. So you can be rest assured that the quality of the product is, American made and tried and true. For those of you who want to learn more after this presentation and happen to be at OSET this coming weekend, we'll be there. So definitely try to stop by the booth. But with all that being said, let me quickly introduce Dr. Wang. Dr. Wang is the chief of sports medicine at UC Irvine. He specializes in biologic joint preservation techniques. He's been a great friend and a great person to have that has an open mind and has been willing to try something that we view as being sort of a paradigm shifting technology in the field of autologous biologics. And when we tell someone that they don't need a centrifuge bone marrow, we usually get a few eye rolls, and then by the time we're done with that conversation, they're at least willing to engage a little bit further. At the top of the screen, you will see that there is a Q&A button. I do ask if anyone does have questions, just shoot them in there and not the chat, just to keep things organized on our end. There should be plenty of time for questions. I think Dr. Wang plans on speaking for 30 to 40 minutes, and we have till about 9 o'clock. So yeah, should be plenty of time to hopefully get to all the questions. So without further ado, Dr. Wang, floor is yours.
Sure. Thanks, Harlan. Again, my name is Dean Wang. I'm at University of California, Irvine. I'm an orthopedic surgeon. I specialize in sports medicine and joint preservation techniques. Starting off practice and still very skeptical initially with any sort of biologic and treatments, including bone marrow aspirate, BMAC, stem cell type injections. But especially with this system, the more I looked into it, the more it made sense to me. And like Harlan said, I think this is truly paradigm shifting. And there's a lot of history of how CERVOS and Ranfac developed this specific needle called Marrow Cellution. So first of all, you guys can hear me okay? No issues with seeing the presentation and hearing me? I'm assuming that's a yes. So, okay. Let's go ahead. So our agenda for tonight, I'm going to keep this short, talk short so that we can have plenty of time for questions and discussion at the end. 4 main points for this talk. First is my indications for treatment of bone marrow in sports medicine, and as I prefaced, pretty limited in terms of my indications right now for the moment. I'm mainly using it for osseous healing. A little bit about the conventional bone marrow harvesting systems and their pros and cons. What is the ideal harvesting technique based off of the evidence we currently have, and then the current evidence behind Marrow Cellution and their specific needle. So first, we'll start off with the indications for treatment using bone marrow in sports medicine. So I want to start off with a clinical case. This is a case that I think that a lot of people have seen. This patient in particular is a 29-year-old pro hockey player with progressive anterior knee pain. He's been treated all by outside providers, and this is his initial MRI. So what we see is that there's obviously some bone marrow edema in his medial half of the patella. But his cartilage surface is overall not too bad. A little edema and blistering of the cartilage, but overall that layer is pretty intact. So he, after the season, initially undergoes an chondroplasty, arthroscopic chondroplasty, and outside-in drilling to treat that bone marrow lesion. He rehabbed appropriately, but a few months later still had continued knee pain, couldn't really skate, couldn't really push off. And this post-operative MRI shows that, that bone marrow lesion is still existing. Unfortunately, that outside-in drilling has caused some damage to the subchondral plate, and the cartilage is starting to thin out a little bit and become irregular there. Because he's not able to get back to his sport pain-free, he undergoes another arthroscopic chondroplasty, and still, even after that second surgery, is not able to get back to his workout activities and skating. And this is what you see in subsequent MRI, where now that subchondral plate is very irregular. Although the bone marrow lesion is resolved, that subchondral plate is now damaged, and that has affected some of his cartilage surface. And so he eventually went on to require an osteochondral allograft transplantation for this, for a simple bone marrow lesion in the patella initially. So these are very, very, very difficult issues to treat, in my opinion. I do think that we should think of the joint, any joint, not just the knee, but any joint, as an organ where there's several components to that joint that crosstalk and contribute to the arthritic disease. It's not just the cartilage, but also the bone and the synovium, even the ligament and tendon tissues inside the joint, I think, are contributing all to this inflammatory process and eventual OA. I do think there's an integral relationship between the articular cartilage and subchondral bone that we don't quite understand yet. But what we do think is that the health of that subchondral bone is correlated to the overall health of their articular surface, and perhaps we should be treating these bone marrow lesions a little bit more aggressively in the setting of an intact cartilage surface, and not just doing a chondroplasty. So bone marrow lesions have been correlated with a lot of issues and cartilage degeneration. Patients with both OA and bone marrow lesions are 9 times as likely to progress to a total knee replacement over a 3-year period. Bone marrow edema, I also do hip arthroscopy in my practice and treat a lot of AVN. Bone marrow edema seems to predict collapse of steroid-induced hip AVN. Even after a cartilage restoration procedure, bone marrow edema seems to predict graft failure after ACI or MACI, as Tom Minus has showed. So for any sort of cartilage lesion where I see bone marrow edema, I'm thinking more about replacing that bone rather than doing a cartilage treatment only, such as a MACI. Even bone marrow edema on a 6-month MRI after osteochondral allograft transplantation predicts failure. So there's something with the bone that I think is being undertreated or that we don't quite understand that's vital to cartilage health. And perhaps our treatments with bone marrow aspirate and percutaneous injection, which is what I use the BMA for, has a role in these patients. So again, most of the time I am using bone marrow aspirate in my practice now for osseous treatment to treat bone marrow lesions. I mix the BMA with injectable DBM bone allograft, and that way I can inject it into the bone and stimulate a healing response to treat that bone marrow lesion. This is images of a patient that I treated with an intact cartilage surface, but she seemed to have this bone marrow lesion that was significantly bothering her. And treating her with arthroscopy, it confirmed that her cartilage surface was fine. And so I took a little bone marrow aspirate from her iliac crest, mixed it with DBM allograft, and then sort of percutaneously drilled into this area and injected into that bone marrow lesion. And that seemed to help to stimulate a healing response, and she's doing well after that. I do a fair amount of hip AVN, cord decompressions for AVN, and other than just drilling and decompressing the bone, I do also use BMA, mix it with DBM bone allograft, injectable bone allograft that I can use to fill in the areas where I cord out, but also to help stimulate a healing response there. What about bone marrow aspirate for osteoarthritis? I'm not doing this consistently for everyone, but for select patients, I've started to do this more. there's more and more evidence showing that, like PRP, bone marrow aspirate has anti-inflammatory growth factors and cytokines. And so a patient like this with, KALE grade 2 or 3 arthritis, where they're too young for a knee replacement or don't want a knee replacement, I'm starting to offer this more, where I combine an arthroscopy as a sort of a cleanup procedure with the injection, and just so that insurance covers the arthroscopy, and I don't charge them for the stem cell treatment. The hospital eats the bill, and I learned this from Anil Ranawat, where, if the hospital ever comes back to me and says, hey, we're losing money on these BMA kits, I say, hey, well, I'm bringing in more business that you can charge a facility for, by offering this stem cell treatment for essentially free. Patients, when they hear that, they said, sign me up. I think it's a relatively low risk. I think there's more and more evidence, like I said, showing that the BMA is anti-inflammatory. So this is something that's an option instead of charging a patient, $3,000 for a stem cell injection. So Robert Laprade has shown in various studies, including this one, that in PRP and bone marrow aspirate, even in concentrate, that there's a lot of good anti-inflammatory cytokines in these concoctions. The bone marrow aspirate concentrate had a higher IL-1RA concentration, and then a lot of good growth factors just for cartilage health. So not only can BMA be used for bone, it seems like it can be used intra-articularly for osteoarthritis or sort of any low-level anti-inflammatory treatment. So again, let's go over the conventional bone marrow harvesting systems and why there's some drawbacks to them. So the majority of systems, as most of you are aware of, involve some sort of JMCD needle that gets placed. The bone marrow aspirate gets drawn, typically around 60 or more cc's. It gets placed through a 200 micron filter to get rid of all the bone spicules and blood clots, etc. And it gets placed in a centrifuge to spin down to isolate away the red blood cells, the platelet poor plasma, and that buffy coat with the growth factors is what eventually gets isolated and injected or used for some sort of application. So here is a video of a typical harvesting technique that I got just from YouTube from a stem cell clinic, where the JMCD needle gets placed into the iliac crest. And as you can see, the needle is not moved. The syringe is slowly drawn, but then this is a typical harvesting system where, with negative pressure, they collect about 60 or so cc's that gets mixed with ACDA or some sort of blood anticoagulant, and then that gets spun down and then injected into a joint. The problem, so these traditional JMCD needles were designed for hematology, oncology, pathologic evaluation. And what our hematologists have known for years is that when they typically harvest just a small amount of bone marrow, knowing that anything more than that will lead to excessive peripheral blood dilution. There is peripheral blood within the iliac crest. So after the first few cc's, anything that they're drawing out, if they don't move the needle, is really blood, which has a low concentration of MSCs and stem cells. And in fact, there's some data showing that dilution starts even as a little as a 0.3 cc's drawn. So, the reason for that is because these traditional BMA needles have this design where, most of the aspirate is coming from the distal end of the cannula. There are these side fenestrations to pull from the lateral aspects of the endosteal surfaces, but the fluid will always flow to the path of least resistance, which is the biggest diameter hole, which is at the distal end of the cannula. And so, the techniques that call for trying to draw back that needle and then aspirating more are good in thought, but in fact, the blood is sort of pooled in that area. So without any rotation and just a simple drawback, you're still getting mostly blood from that distal cannula. And so there, the solution to that was to just spin it down and concentrate it. The problem with that is that Well, first, before it gets spun down, it has to be passed through a filter into 200 micron filter to filter out bone particles, which can be actually helpful for osseous healing, cellular aggregates, and clot. But my question is, when it gets filtered, are some valuable osteogenic factors being filtered out at the same time? So, the act of filtering can eliminate some of the wanted factors that you want for healing. And then what about with the whole spin process? Well, most commercial systems involve a couple of 1 or 2 spins to make the BMAC, which consists of supernatant with platelets, buffy coat, and the top layer of the red blood cells, which contain the MSCs. So when you spin it down at a certain speed, as with a certain time, these are the 3 layers that you get, where the red blood cells are pulled in the bottom, plasma's up top. This is platelet poor plasma, and then the buffy coat in the middle. The buffy coat has again, where all your stem cells are going to be, but also a lot of your leukocytes or white blood cells are going to be there as well. And so because the PPP and the red blood cells get thrown out, I question, and a lot of other people question, whether some of those osteogenic factors get thrown out as well. So again, through this whole step of traditional bone marrow harvesting and concentrating it with a traditional needle, with traditional techniques where the needle's placed in a single position and 60 cc's of blood are drawn, I believe, and a lot of people have proven that this aspirate is significantly diluted with peripheral blood, which lowers the concentrations of stem cells and growth factors. And then with the filtering process, a lot of the potential osteogenic factors are being filtered out. The other thing that's not mentioned here is that currently within that whole process, that aspirate is potentially being passed off from a sterile field to a non-sterile field and then passed back onto a sterile field. So there can be potential areas where there's some contamination of that aspirate. A lot of the high quality denser cells are lost in that red cell layer during decanting. And at the conclusion of this, although the bone marrow aspirate has concentrated some of those MSCs, it is really an inefficient way to collect, what you want. And there's typically less than 60% of the original cells being successfully recovered. So what is the ideal harvesting technique based off of our historic studies? Well, again, just to review, the cells that we want to get within the bone marrow are these MSCs, and typically they're along the end osteal surfaces of the iliac wing. You have other cells that are being collected, your bone cells, your leukocytes, adipocytes, macrophages, and I don't think we honestly know what kind of cells and what concoction we need for for the specific pathology. I think every a tendonitis is going to be a different concoction or ideally treated with something different than versus osteoarthritis versus potentially trying to augment some meniscus repair. So I think there needs to be more studies into what exactly is needed to augment the healing of tendon tissue, of cartilage tissue, of ligament tissue. But at least, with our current techniques, we're just sort of drawing everything and trying to isolate the MSCs or the stem cells that act as sort of messenger cells in the whole healing process and anti-inflammatory process. So what a lot of studies have shown, and George Mushler sort of started this in the late 90s, is that less is more. If a larger volume of aspirate, more than 2 cc's from a given site, sort of draws out more peripheral blood, which dilutes what you want in terms of MSCs. So with additional volume contributing to little to over a number of bone marrow cells, and principally involves drawing peripheral blood and results in unnecessary blood loss. There's another study showing that marrow harvesting by means of multiple small volume aspirations minimalizes that dilution and results in a greater number of cells and hemoprogenitors. And Hernegu has really demonstrated this, where he takes about 30 minutes sometimes or an hour to really collect his MSCs. In his rotator cuff augmentation studies and his osteoarthritis studies, he's taking a small needle, aspirating maybe a half a cc or cc at a time, redirecting it into the iliac crest, drawing. It's a long process that he does just to be able to maximize his MSC count. Again, study here showing that that nucleated cell concentration was threefold, and the CFU count was tenfold higher in the first puncture of the first cc of the bone marrow aspirate, rather than a full draw of 60 cc's. And then this study here showing that, again, small volume marrow aspirations and multiple puncture sites in multiple locations results in a higher concentration of progenitor cells. This is one of Hernegu's study in 2013, where he looked at not just the amount that you're drawing out, but also the size of the syringe. So he looked at MSC concentrations in bone marrow aspirate from harvesting with a small 10 millimeter syringe versus a 50 milliliter syringe. And what he actually found was that in that smaller syringe, the bone marrow aspirate had a 300% greater concentration of MSCs compared to a 50 milliliter syringe. That's even with just drawing 1 cc. And what you notice on the graph on the right here is that, especially on the bottom with the MSCs, is that when he's drawing only, say, 1 cc at a time, that first draw is where you get those MSCs. And then the more sort of you draw in that syringe, the more you fill it up to 100%, you'll get a lesser concentration of MSCs. And with the theory behind this is that with a smaller syringe, it's easier to draw a plunger at a higher speed versus a larger syringe. Those MSCs are attached to the endosteal surface, and you do require a little bit of force, vacuum force, to draw those MSCs and detach them from the bone. So it is thought that first cc or 2 is the most important. That's where you get the highest concentration. And with a smaller syringe, it's easier to transmit that vacuum pressure. So a smaller syringe seems to be better than a bigger syringe, even when drawing the same amount. Which brings us to the Marrow Cellution product. This is a needle specifically that, compared to traditional needles, draws from the lateral aspect, so there's less peripheral blood dilution. It's a technique where it's using a 10 cc syringe where it results in multiple blood draws. So, I think it improves the current technology, and instead of having to insert that needle multiple times, with this needle design, it allows us to still know what we know from those studies that I just cited, and it allows for aspiration of the MSCs from multiple areas of the iliac crest through a single puncture. And the way it does that is that this specific needle, after you put in the Jamshidi needle, you put in this this insert, which closes off the distal end of the needle, so that there's no peripheral blood dilution. There's no aspiration, mainly from the distal end. And so all of that draw is from the lateral fenestrations, which is what you want. Because, of course, those MSCs are on the endosteal surfaces, and you want to draw from the sides. The other nice thing about this this design is that it has a screw mechanism which allows for relocation of the cannula. So once you inserted it in, then you can grab this handle and twist it, and that allows for a controlled withdrawal and rotation, so that you can draw the MSCs from different locations. So I think that with this design, you don't have to puncture multiple times into different locations of the iliac crest to get what you need. So here is a, so again, this is equivalent to fracking of the bone marrow. The Marrow Cellution draws from multiple untapped geographies of the iliac crest to maximize cell yield and purity. And because that distal end of the cannula is closed off, it doesn't draw peripheral blood as well. And so you got a nice controlled draw. So this is the video using one of the older systems of the Marrow Cellution. Again, with a sharp needle, you insert into the cancellous table. This is an optional step, in my opinion, where the sharp gets removed. And you can draw a little bit here just to make sure that you're inside the right place. But it also allows you to collect a lot of that bone marrow, just 1 cc or so, highly concentrated in MSCs. This is where afterwards you put your blunt in, get into the deep area of the endosteal table. And this is an older system where that screw mechanism was placed onto the skin. With the newer system, you no longer need that. This is the aspiration cannula that closes off that distal end. And then this is where you do small little bursts of about half a cc or so to draw that bone marrow, highly concentrated in MSCs. And then with that screwing mechanism, you can slowly withdraw and rotate and gather from multiple areas of that iliac crest. Usually for an arthritic knee where I want to only inject about 3-4 cc's, this is very rapid. I only have to inject or aspirate 4 cc's. If I'm using this to augment an osteochondral allograft transplant or for my BMAC, for my AVN patients where I'm mixing it with bone marrow, I'm taking more time to draw closer to 10 cc's of this. So what's the evidence behind the Marrow Cellution device specifically? We have very few studies looking at this device, and there's more in the works. This is comparing the CERVOS product to a Biomet product that uses the centrifuge, and the CERVOS sample had approximately twice the CFU counts and greater number of medium and large CFUs compared to a traditional centrifuge system. This is the latest study from Elisaveta Cohn in Italy. There are 3 main purposes of this study. This is a study that characterized the bone marrow aspirate from Marrow Solutions, from the bone marrow aspirate from patients. The second aim was to look at the in vitro efficacy of the bone marrow aspirate that was drawn from these humans in a model of cartilage inflammation, a 2D in vitro model where they cultured chondrocytes and stimulated them with IL-1 as an inflammatory model, and then treated that model with the BMA drawn from the patients. And then, of course, looking at these 10 patients or so that they injected both into the knee and into the bone marrow lesion and reporting their clinical results. So this is aim number 1, where they specifically characterized the bone marrow aspirate drawn using Marrow Solutions. And what they found is that this is very typical even in a centrifuge system where there is a low concentration of MSCs, but 0.011 is typically the highest that we can get with even a conventional concentrate system. So without a centrifuge, they were able to get a bone MSC concentration on par with the centrifuge system. So again, with the centrifuge system, it takes about 20 minutes to spin down. So even if there's equivalent amount of MSCs, the Marrow Solution system saves on some time. They cultured this and looked at doubling time and showed that even with multiple passages that there are in fact MSCs in the aspirate. Aim 2 was looking at an in vitro efficacy of bone marrow aspirate in a model of cartilage inflammation. So again, they looked at chondrocytes in a 2D layer and hit them with the BMA. They also hit the chondrocytes with IL-1 beta, which is a pro-inflammatory cytokine, and then combined it all to see what the response was. And they did PCR to look at the gene expression. MMPs are a matrix metalloproteinase. They're pro-inflammatory. They degrade cartilage. And so, of course, with normal chondrocytes, you expect a low level. With the bone marrow aspirate, again, low level. When you hit them with the pro-inflammatory cytokine IL-1 beta, of course, the gene expression gets increased. And then with the BMA, it seems to lower that expression of MMP. No change in TGF beta, which is a pro-inflammatory pro-chondrogenic cytokine, and TIMP1, no change in that. TIMP1 is a anti matrix metalloproteinase, so no change there. But the main thing is that what they showed is that it's actually the BMA was in fact anti-inflammatory. The third aim was to see how these patients did. And in these 10 patients with an average age of 52, with a sort of intermediate, so mild to moderate OA, what they showed is that increase in IKDC scores, pain VAS scores, and KOOS scales, subscales. So overall improvement in their pain and function of the knee. Lastly, this is a study looking at the Marrow Cellution system or multiple systems where they examined the effects of the needle. They looked at 3 different types of needles: the Marrow Cellution needle, the Arthrex needle, and argon needle, amount of volume aspirated, and the aspiration technique, whether it was good to aspirate from a single site or reorient their needle. And their main outcome was CD34 plus cell counts, not specific to MSCs, but sort of a generic marker for mononuclear cells. What they showed is that the Marrow Cellution needle seemed to have the highest mean CD34 cell count compared to the Arthrex and argon needle, where again, those needles were where it drew from the distal end of the needle. And so it seems like with that aspiration cannula closing off that distal end, that the needle itself was able to draw more of those cells. And then the study also confirmed that smaller volume aspirations had higher cell numbers than larger volume aspirations in all groups, and multiple aspirations of about 1 to 2 milliliters with reorienting to a different location enhance the cell output compared to a single suction from a single location. So I think that this Marrow Solutions needle sort of is designed to not only draw small amounts, but draw from the lateral aspects of the needle so that you don't get peripheral blood dilution. And the screwing mechanism allows for being able to relocate that needle easily, which makes the procedure very, very, very fast. It keeps it sterile, and it prevents the need for a centrifuge to get an aspirate with high MSC counts. And so, again, in conclusion, there's increasing indications for use of bone marrow aspirin in orthopedic surgery. Obviously, you know, a lot of the evidence right now is for osseous healing in non-union surgery, and then, but there's more and more evidence showing that's an anti-inflammatory. I do see it being used more and more as an augmentation strategy in soft tissue repair. The original bone marrow needles were designed for hematology and do not have a method to limit peripheral blood dilution. And the current BMAC systems require significant time, usage off the sterile field, and are limited in capability. The Marrow Cellution product with this recent version has overcome a lot of those limitations of a traditional needle to maximize purity, cellularity, and cellularity at the source, eliminates the need for a centrifuge, and makes the aspiration procedure very, very, very fast. So that's all I have, and looking forward to discussion and answering any questions.
Much appreciated. Fantastic presentation, as always. You know, there's a few things that always come up in conversation, especially with physicians that haven't maybe done a bone marrow aspirate since medical school. What can you share technique-wise in terms of, you know, targeting the PSIS, or I don't know if you ever go anterior, but
yeah, I actually only go anterior. I don't do this in the office setting. I'm usually using these more in the during surgery. But you know, the technique is sort of the same. You know, and I actually don't. So I actually do this sort of semi-sterilely, where before prepping the knee, I actually just once the patient's asleep, I cut a hole in a towel. I prep the hip, and then I just place that towel over, and then I just use sterile gloves. The next thing I do is I have my tech put all the supplies I need for the bone marrow aspirate on a sterile Mayo stand, but it's sort of off the field, away from anything else surgical. I take my sharp needle, and I literally just poke the skin. I don't make an incision. I poke the skin over that anterior iliac crest. And then in the bigger individuals, you can actually sort of move some of the adipose out of the way and poke it. And when you let the adipose down after you're done with the procedure, that helps to just sort of tamponade and prevent any bleeding. But what I'm doing with my two fingers is that I feel the inner table and the outer table of the iliac crest, and I literally just poke through. Once my needle is through the skin, through the subcutaneous tissue. I feel the inner table, I feel the outer table, and I just sort of center it. That's where I then isolate it with this hand, and then I just sort of mallet through. And I think with that technique, it's been reliable in entering the cancellous table. I really don't check. I just sort of bang, bang, bang. And then, with the sound of my mallet hitting it, again, the patient's asleep, and that's why I like to do this when the patient's under anesthesia. I bang, 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 bang until I know that I'm at the bottom of that iliac crest. And what you'll hear is that the sound goes from a higher pitch sound to a more lower pitch sound. That's when I know when to stop. I exchange the needle out, I put in the aspiration cannula, and that's when I start my bone marrow aspirate. But it's relatively easy if you use your hand to feel the inner and outer aspects of the table. So you know that you're in the center and that you're into the cancellous bone.
Mm-hmm. There is a question regarding a filter that CERVOS does carry in its portfolio. It's not included with the Marrow Cellution device, but I don't know if you have any experience using the filter. Is that something you would consider to filter out some of those potential bone fragments or spicules, really?
Is it a 200 micron filter? Same.
I think it's 150 even.
150. Yeah. I mean, I think I would consider using that filter if I'm injecting the bone marrow aspirate inside the joint, just because I don't want bone spicules floating around in the joint. But for, any sort of bone healing issue, I actually want to keep those because again, filtering out the clot, the bone spicules, I do think that eliminates some of those osteogenic factors that we want.
That's great. Looks like I don't know if there's any more questions. So unless anyone has anything else, we can end this webinar early. But thank you again, much appreciated. Again, if anyone has any questions, reach out anytime. I think that this webinar is recorded, so we'll definitely share it with everyone after. And there will definitely be more to come. So appreciate your interest in our technology and hope to be in touch soon.
Thank you, everyone. And thanks, Harlan, for allowing me to speak on this. And
Excellent.
hopefully I see you guys in Vegas this weekend.
Looking forward to that.
Yeah.
Thank you.
All right. Take care.